My name is Fritz Stevens-Tyling. I'm on the board of Mid-Valley Healthcare Advocates. I'm also the co-chair of the Outreach and Communications Committee. I want to welcome all of you to our town hall tonight. We're excited at the topic that we're going to be talking about, especially excited about the panelists that we have who are going to share some information with you and also answer a lot of questions. The whole idea behind this is we want to hear from you. We want this to be an interactive session. Fortunately, there have been a number of people that have already posted questions for us online. Like I said, what we do is a bunch of volunteers spending a lot of our time and our energy working on this. A lot of what we do as well, there are some things that do cost money. So we'll talk a little bit towards the end about if you're willing to help contribute to Mid-Valley so we can continue to do the good work that we do. So I'm going to go ahead and introduce our panel. Then each one of them will have an opportunity to spend about 10 minutes sharing some information. And then we're going to go into our interactive portion of the evening where your questions are going to be very important for us to hear, and we'll have some really good dialogue. Everything sounding okay? Okay. Wonderful. So just to my left here, Dr. Tony Germann. Tony is the Vice President of Healthcare for All Oregon. He's also a member of the Oregon Health Policy Board, and he's also a primary care physician, correct, up in the Woodburn area. He'll have some good information to talk to us about, especially marginalized communities and so on, and the healthcare delivery and gaps and all those types of things. Next to Tony is Dr. Miriam McDonell, who is the Executive Director of the Oregon Universal Health Plan Governance Board. So a lot of the questions that came in before the session were about, what's the governance board doing? Where are we going? What's it going to cost us? All those types of.
Also in the space that I like to bring up, I've been in health policy for about 20 years now, and thinking about the concerns we have about the uninsured, but we don't talk enough about those of the breadth of our healthcare system. And that's really where I think HR 1 is going to be very impactful for people. And I don't think people really realize the consequences of what the decision making this last year and how that's going to impact not just the marginalized communities and those that are uninsured, but really those that are underinsured. And now a good majority, I would say, of us in the room have insurance, perhaps by our employers. That's about 50% of the country has health insurance in that way. But the impacts of HR 1 is that we are going to see all of our payments as far as for our premiums and our deductibles and copays go up in this next step. We're also going to see how our economies and how our communities are supported. Healthcare is a big industry. It's about 20% of GDP, closely, about 19% now. So as far as when we withdraw a lot of dollars, and what we're talking about coming just to the state of Oregon is $8 billion over the next 3 biennium. So this upcoming year, we're going to see $200 million that's going to be withdrawn with HR 1. And then the second, we're going to see a little over $3 billion. And then following that, it's going to be $4 billion that's going to be removed from our economies. That's really going to impact rural communities and communities such as where I work and smaller hospitals, those in Eastern Oregon and Southern Oregon. And I like to draw, how we've constructed healthcare system is we've subsidized a lot. A lot of people don't really understand that about all healthcare dollars are subsidized in some fashion or another. 94% of all healthcare delivery is through that function, whether that's a tax break on employer-sponsored insurance. That's where almost a third of people get healthcare through Medicare and also in Medicaid. And with the Affordable Care Act, we have really tried to construct a scheme where we were trying to solve the problem getting everybody healthcare. We're saying we're just going to get them coverage. A lot of health policy is about saying, yeah, it's great. We've got 97% insured in this state. Right? Look at other states. We're doing phenomenal. I'm a physician, and so if I'm going to do an intervention, I'm going to give you a blood pressure pill. I want to know, is that going to change your outcome? Is that going to change whether you go into a hospital or you're going to have a stroke or a heart attack? Does that intervention equate to the merits of giving you that intervention? And what I come to really try and point out for a lot of people is that the interventions we've done over the last 15 years are incredible and innovative. And a lot of people have done a lot of great work in our own state and at the federal level, initiatives to try and get people politically. That was what was feasible for the Affordable Care Act. But we're seeing is, again, that curtain being pulled back to the flaws and the innate problems that happened with the Affordable Care Act. And what we did is we subsidized a bunch of Medicaid. We subsidized a bunch of the marketplace exchanges that made premiums affordable for people. I need to add into this story a little bit that what we've done, particularly with the Biden administration, is expand those subsidies in the market-based exchanges, and those were not renewed this year. So that's another big piece of this puzzle where come January 1st of this year, some families saw their premiums per month quadruple. Some families are paying almost $2,000 a month to get healthcare coverage. And the consequences of that is that the out-of-pocket spending, because of the deductibles and the co-pays and the cost-sharing people they have, are no longer feasible to make that. Many of you have heard the story about the number of bankruptcies that are associated with healthcare spending. You know, there's a recent study that was published just last month looking at the cost burden that people face. And sometimes we look at just in 1 year, but we haven't really done the study to say over the course of several years, what does that impact mean? So over the course of 1 year, this is Adam Gaffney's study that looked at over the year, what would be impactful for people. And the way they qualify this is 10% of your income for the year would be qualified as a cost burden for somebody. 6.5% of Americans each year face that cost burden. Over the course of 4 years, that it goes up close to about 18%. And think about that. So that's 10% of somebody's, and what we see is that 100 million people in the United States, 100 million people, you know, our population is 330 million, about 340, I guess. And 100 million people are in medical debt. One in seven are in active debt collection. And again, back to what we've done innovatively and creatively to try and do all these different pieces in our state alone, again, we've gotten 97%. But back to the equation, does the intervention giving someone a blood pressure pill improve them from having a heart attack? Is what we've done with the Affordable Care Act or what we've done with all these different interventions getting what we want? Is it protecting people with financial insecurity? And we don't have financial insecurity when it comes to healthcare. People in my clinic with HR1, I'm going to sit 3 feet away from them, and they're going to come out of the ICU because they didn't have their COPD meds. They couldn't fill their inhalers. In Oregon, about 17% of people forego care that would be indicated to them. There are some studies that it's actually 1 in 4 people are going to skip a drug that was indicated for them. 1 in 4 people are going to skip going to a doctor visit. 1 in 4 of them are going to skip going to a treatment that was indicated or a procedure. And what I think a lot of people are here and encourage the conversations tonight, because I'm really excited about this next person who's going to tell us what we're doing about it. Because that's the direction I think we need to go. And I served on the Bridge program for the state of Oregon that included access for people to get 138% to 400 federal poverty level. My concern with HR1 is that I think with the subsidies being withdrawn, that program is going to be impacted. The innovative structures as far as advocacy we've done for Cover All People, which was expanding health insurance for people that were undocumented in Oregon, is going to be considerably withdrawn. I'm very worried about the impacts of Medicaid. We know that 200,000 lives with HR1 are going to lose health insurance. And already this year, we've seen with the market-based exchanges that 15% of individuals didn't sign up for the market-based exchanges this year. So we're already looking at going back in time. I just want to remind people, we're in 2026. The political feasibility of moving towards a unified payment system is here and it's now. And it takes people power. And I really appreciate all of you being here because we're going to do it. It's taken us a very circuitous route, but it takes, and putting on my hat of Healthcare for All Oregon as vice president is, I'm seeing more and more people sign up for us to support this effort because it is a politics issue. It's not necessarily a policy issue. We have all been trying to reach universal health care for over 100 years in this country. And I think it's high time we actually get it done. So I will pass on.
Dr. McDonell, I think we can turn that one on there. And
all right. So I'm going to ask Mike, I don't know, I did have a presentation, but I don't know if it's available.
and
I emailed it.
you emailed it to Mike.
Yep, that's okay. Do you know if the presentation that I sent to you is, if we're able to bring it up? Sorry, I should have warned you ahead of time. While he's doing that, I will do a brief intro as well. Dr. Germain, Tony forgot to mention that he is also actually a committee member on the Plan Design and Expenditure Committee of the Universal Health Plan Governance Board. So I think probably one of his greater accomplishments. So thank you for also doing that. So, thank you all so much for being out here tonight. My name's Mimi McDonell. I'm a OBGYN by training, so I too have gotten to deliver a lot of babies, which is really a lot of fun. Becomes a little bit less fun at 2 a.m. And my career has taken me in many different ways. I had the opportunity, I was a owner of a practice. I had 2 other OBGYNs. I live in the Dalles and I've lived there for over 30 years. I've also worked for Mid-Columbia Medical Center, so I was employed through a hospital. I was a local public health officer for 10 years, all through COVID, which is really when my sort of love of population health and sort of this larger outlook was developed. I worked for CCO, Columbia Gorge CCO with Pacific Source. So I was a Medicaid medical director and also in Medicare. And then since this past, I got a master's in population and health systems management, so learned a whole lot more. And then since April, I've been the executive director for the Universal Health Plan Governance Board. So I am here tonight actually speaking in my role as the executive director of the Universal Health Plan Governance Board, which I'm really delighted to do. I will just warn people that there probably will be a lot of caveats and me saying, the board hasn't completely decided, so you'll just all have to bear with me. But what I'd like to do is kind of give you an update of what the Universal Health Plan Governance Board is. It's quite a mouthful. And where the board is on the effort that we have right now to really create a roadmap to find a unified financial system for healthcare in Oregon, and how not all of the details are worked out, but how at least I think some of the details that we can really start the conversation and start hearing back from people like, yes, we think that's the right direction, or no, I think we need to go somewhere else. So if you want to, are we ready?
Yeah.
Super. Sorry if I'll kind of try and keep up here. So that's me. And I think you kind of have 2 going on at once there. So I'm not going to worry too much about that. So sorry, folks. I won't spend too much time on the current state of healthcare. Tony Germann gave you a nice synopsis, and I think everyone here is living in that reality that healthcare is fragmented. Our healthcare delivery system is fragmented, inefficient, it's expensive, and it's inequitable. And if you want to go to the next slide, if you can, one of the things that I think is incredible about Oregon is that the people of Oregon feel strongly enough that healthcare is a right. So in 2022, ballot measure 111 was passed, which amended the Oregon Constitution. Well, we can see it up there. So just in case anyone's not familiar with it, I have it in front of me here. It says, it is the obligation of the state to ensure that every resident of Oregon has access to cost-effective, clinically appropriate, and affordable healthcare as a fundamental right. That's what the people of Oregon believe, which is pretty tremendous. We're not quite there yet, hoping to get there. So to take that a little bit further, Oregon has passed legislation to explore the possibility of a universal health plan. And so you might want to move along a little bit. So the Universal Health Plan Governance Board was created by Senate Bill 1089, which is now the ORS 751. So the goal was to design administrative and financing options for a single payer, a unified financial system to provide care for all of the people living in Oregon. Now, there are 9 volunteer board members. Dr. Chun-Wei Chi is one of them. He's right over there. You can give a little wave, Chun-Wei. One of our many dedicated board members, made up of healthcare professionals and public engagement representatives. There are 3 full-time staff. I'm one of them, the executive director. And what we are providing is a report, a proposal that will go to the Oregon legislature in September of 2026 of this year, but the work doesn't end there. So, it's looking good. Do you want to go on to the next slide? All right. Like all good boards, we have a mission statement to create a strong, workable plan so everyone in Oregon can get the high quality, equitable health care they deserve. And the design of the plan is that it will be more simple, affordable, and more sustainable. So families and businesses will have lower cost, and so we can have a healthier, more stable future for our state. So we can move along to the next one. I'll just talk a little bit about what the board started off doing. This was before I got there. So they kicked off in April of 2024. They had overarching principles, which of course you need to guide this work. So their overarching principles are health equity to maximize health, fair distribution of medical resources, minimize financial hardship for individuals and for families, and also a community sense of ownership. They did this, they developed, so there was the board, and then they developed several committees. As I mentioned, Dr. Joanne's on one of them, plan, design, and expenditure. We have a community engagement and communications committee, finance and revenue, operations, and we're just kicking off our transition committee. Oh, we're back onto, I don't know what. Anyway, we have a bunch of committees, which is good. So let's start talking about kind of the fun stuff. So what would be in this plan and who would it be for? So I'm going to call these the proposal elements. So this is where the board has landed on with help from the committees and a lot of work. And of course, a lot of work that has come before in Oregon through the Joint Task Force report, which was tremendous, laid a lot of the foundation for this. So eligibility, who should be eligible for the plan? Well, all people who live in Oregon should qualify for the plan. That's it, full stop. People who there have been some other things that I think are really important is that the coverage is not related to anyone's employment or lack of employment. So it's not connected at all to employment. And then what about healthcare benefits? So we know through the Affordable Care Act, there are certainly benefits that are required to be in a health plan, which is great. But the people who have gone before, again, with the Joint Task Force and also with the committees and the board that we're at now, believe that to truly enable people to live their healthiest lives, that they need to have what we call a little bit more robust than just the basics. So the plan benefits are based on essentially what state employees, which I happen to be one of them, kind of like what's called Public Employee Benefit Board, just your a health plan that many people's employers would provide for them. So a health plan where you, at this point, the decision was that dental would also be covered within this health plan, and vision, and other types of benefits. So again, this is where I'm just gonna have to say it a couple times. This is where the board is at right now. I can't promise that that's what the final proposal will be, but this is where we're at. I think one very significant thing that people have talked about is that in terms of having a choice of provider, I think many people have had health plans under managed care where you can see one set of providers and maybe you can see another group, but you may have to pay more because they're out of network and maybe you can't, your insurance isn't going to pay for another provider. Within this universal health plan, the idea is that individuals who are covered by the plan, they'll be eligible to see any authorized provider within the state. So essentially no networks. That usually makes people pretty stoked. No networks is fun. It's a good idea. I think for those people who've been involved within the healthcare system, of course, we want to have high quality for healthcare for certainly the people who are in the receiving end of healthcare, not only in terms of the outcomes of people, but also high quality in terms of trying to keep costs at a minimum. However, sometimes some of those quality efforts can become incredibly administratively burdensome. If anyone has ever been in an office and has had their provider spend a good 20% of their time kind of looking into the computer and clicking boxes and things like that. And so one of the desires of having a universal health plan is that the quality will still be there, but it will be, the way to measure it will be much more streamlined and efficient. And so then there could be, again, if you can think about it, a uniform quality policy. So people are measuring the same thing, and then providers have what people call clicking boxes, spending a lot less time clicking boxes. In terms of affordability, there would be no premiums, no deductibles, no copays, and very much most likely there will be just zero what's called cost sharing. I can't say for sure that it will completely be zero because there's some discussion that possibly for some medications, sorry about that, there may be some cost sharing. So that one is not completely ironed out. But in terms of those, certainly at the point of service. So sometimes you all may know, you go into a provider's office and they say, can you, do you want to pay your copay now, or do you want to do this or that? And so it's incredibly cumbersome. Most providers' offices weren't really set up to be collecting money. So being able to take that off of the providers will give a huge relief to the people who are paying the money, but also to the providers' offices who are not, that's not really what they're designed to do, is collect money. The care would definitely be very patient-centered, really focusing on the success that Oregon has with what's called the primary care home models, and also with behavioral health, certified community behavioral health clinic models. And again, in addition, people may not be aware, interestingly enough, that sometimes folks in Oregon who actually are enrolled in the Oregon Health Plan are on Medicaid. They have some access to some behavioral health services that people who are in private insurance or others may not have access to. So the idea would be to expand those behavioral health services to everyone who would be on the plan. So in terms of, let's see where we're at. I don't know if you want to move along or we're good. We can just keep that up there too. That's good. I'll talk a little bit more. I'll kind of keep moving along here. Some of the other things, how would it be structured? So the entity would be a public nonprofit corporation. So you can think Oregon has a couple of examples. OHSU is one of them now, has been one, and SAFE, the workers' comp organization is another. So that will enable the plan to have that public accountability, but with a little bit more operating flexibility than, say, if it were exactly through the state of Oregon. And then the governance board of directors appointed by the governor, confirmed by the Senate, and that would govern the public corporation. There's still a few more. Okay. So that was the fun stuff, like everything that everyone gets, all of it's for everyone, right? So now we're going to have to talk about a little bit about the other side of it, which how might this be paid for? which I think people may be wondering about as well, since I just told everyone's going to get all the healthcare that they want. Which I think one of the main principles that is part of the development of this, and it's been in the development of a long time, is that there is certainly enough funding for a healthcare system with the money that is being paid now. And the idea is that it doesn't have to be sort of quote unquote new money that's generated, but it's really distributing the funds for healthcare, and it's certainly in a more efficient way to actually bring down costs, but then also making sure that it is equitable and that people will contribute to the system based on their ability to pay and not on the amount of healthcare that they use. So really moving the model from being something that healthcare is something that is essentially a commodity, something that is purchased, to something that, if we think about it, as a public good. So the revenue proposal that was put forth has a couple of objectives, and I think this will help folks kind of understand, again, a little bit more of the thinking. And I'm sorry, I'm sure I'm going over. One of the things to get to that universal healthcare for Oregonians, really, it's going to be important to capture as much as possible all the efficiencies and economies of scale from a single payer system. So again, if you think about all of the different healthcare clinics and hospitals and all of the different payers, and they all have different rules and regulations. And of course, it is incredibly inefficient. So having the single payer unified payment system. So that's one of the economic proposal objectives. Another one is to decouple health coverage from employment, so people no longer are afraid to leave a job or are not forced to stay within employment in a place where they don't want to be, mainly because they have healthcare. Another really important factor of this, though, is also, because unfortunately, efficiency won't do everything. It will do a lot, but it won't do everything, but also to work to contain that long-term healthcare cost growth. As we know, as Dr. Germain was talking about how much percentage of the GDP that the United States goes towards healthcare. It's just incredible compared to other countries. It is tremendous. Some of the other important portions of the revenue proposal preserve federal Medicaid and Medicare funding. So in other words, all of the dollars that come into Oregon, the idea is that those will continue to come from federal sources. Some of the other things, we're in Oregon, for businesses that do have corporate income tax deductibilities off their sort of federal taxes that they pay, to continue that. So in other words, not to make the situation worse for businesses. And again, like I said, another component is to have revenue adequacy. So in other words, to make sure that there are enough funds to continue funding this system and to have that financial sustainability. Lastly, this starts to get a little bit into the weeds, apologies, but there's something that's called ERISA, which is the Employee Retirement Income Security Act, which I suspect some of you in this room are some understanding of. So ERISA essentially states that companies are, you cannot interfere with a company's ability in the way that they provide healthcare benefits to their employees. So in other words, you cannot you cannot demand that they follow a certain rule or that they buy a certain type of healthcare. So that's some of the things that you have to avoid is a legal preemption from ERISA. I'll get to that in a second about how the plan is for that. So again, kind of lastly, or not lastly, but if we're thinking about a revenue proposal, again, in the current system, individuals have to pay premiums, deductibles, co-insurance, co-pay, out-of-network fees, out-of-pockets. Now, employers pay as well. Employers pay insurance premiums, or they have self-funded plans, so they pay for that, or other types. And the idea, this is now getting to the revenue proposal. So what would we do differently? Well, instead of individuals paying for all of that, the premiums, deductibles, et cetera, the proposal includes an increase in the Oregon personal income tax. I know people are not excited to hear that, but it is really instead of payments from premiums, from deductibles, et cetera. Employers, there's a plan to have an employer payroll tax. Some of the funding would come from corporations for a slight increase in the corporate income tax and the corporate activity tax. It's a tiny little bit of a lodging tax is thrown in there, which actually would help contribute to people when they come from out of state to be able to, thank you, cover the costs of people who are out of state who don't have the ability to pay. So having a little bit of a lodging tax would do that. So that was a lot. I'm going to do one more thing. I think I'll kind of talk about, how I talked a little bit about cost savings, like how we can keep the costs under control. Again, administrative simplification, prioritize funding of primary care. Oregon actually does a tremendous job of this already. Almost 12% of the funds go towards primary care providers. We want to increase that funding to at least 15%. There's a potential for what's called global budgeting for hospitals, which is a way that actually the state of Maryland has used to keep healthcare costs down, improve coordination for prescription drug purchasing. Hopefully we can get there. I'm not going to blame you though I'm not going to hold you to it. And then something called a standardized fee schedule, which means that instead of people who have Medicaid, if they go to a provider's office, Medicaid pays a certain amount for the same service, Medicare pays a different amount, and then commercial insurance pays possibly 4 times that amount. So that would go away and there would just be a similar fee schedule for everyone. I think I better stop right now so we can turn it over and then we'll take questions. Sorry, that one's so long.
Before you turn that off, will you have a single PBM?
That's the dream.
Good. I'm sorry, I'm stuck here. I'm Brian Mayo. I'm the executive director of the Oregon State Pharmacy Association. I've been here in this role for about 5.5 years now. I appreciate the invite from Mike and Mark to come down and be here with you. I grew up in Corvallis, and it's been about 20 years since I've been in this building, but it's good to be back. So, in Oregon, we have 2 different pharmacy associations. We represent the majority of our members are the community pharmacists and the independent pharmacy owners. And then there's another association that represents the health systems. So we work closely together, but we both have our lanes that we stick in for the most part. And as it pertains to this conversation, there's a lot of topics I could talk about pharmacy and challenges that we're having with like corporate activities tax, trying to get test and treat put into place, standard scope of practice, different things like that. But I think in relation to this conversation, talking about pharmacy benefit managers and even the Prescription Drug Affordability Board is probably most helpful for you. How many people know what a pharmacy benefit manager is? Okay, so for the most part, a quick rundown of them. They're known as PBMs, and there's 3 of them that basically dominate the entire industry. I would say I think it's about 80% of all PBMs go through these big 3, and they're the bad actors that bring down the names of all the smaller ones. So just putting that out there. So with PBMs, they are hired by the insurance companies to basically determine the price of your drug, determine what's going to be on formulary, and what's going to be the reimbursement rate to the pharmacy. So when a pharmacy buys a drug, they purchase it from a wholesaler at a certain cost, and they're not able to take that receipt and submit it to the PBM and say, this is what I paid for it, because they want the pharmacies to go out and look up for what the cheapest price is. So the PBMs have a formula that they use to determine what they think the average for a pharmacy in the state should pay for the drug. So they have that formula. There's also other formulas. Oregon has one specific, and then there's also a national one the Oregon one's called OAC, and then the national one's called NAVAC. That are the national one's determined by CMS, and you're able to take a look, and it's transparent and determine what your price is going to be for the drug when you're submitting the claim. So the pharmacy pays for the drug, and they get a price for the drug back to them from the PBM. Well, the PBM also pays for the overhead and administrative fees, those types of things with keeping the lights on and the heat and the staff and all that type of thing, which Oregon has determined from OHA to be worth somewhere between $10 and $15 per prescription. But when it comes down to it, PBMs are reimbursing for the dispensing fee about 25 cents to $1. So it's hard for pharmacies to stay in business when they don't know what they're going to get reimbursed for the price of the drug that they purchased, and then also getting $1 for a pharmacist's work. That just doesn't make any sense. So we've been trying to do PBM legislation in Oregon the past few years, and have run into several challenges. One of them has to do with a non-doctoring clause that refers to NADAC is unconstitutional based on the Oregon Constitution. And that's a hurdle that we haven't been able to figure out yet that needs to be adjusted for the 2027 session. ERISA is also something that we talk about a lot, and I have a lawyer that I can give you an opinion from that would help out with that topic. So glad to pass along that information. And then there's the Prescription Drug Affordability Board, which I want to see that they're like 5 years old, but in reality, they've only been operating for about 3 years. And they are supposed to look at a total of 9 drugs plus 1 insulin drug to determine what the maximum price should be for those drugs to make it affordable for Oregonians. So they've been going through this process. The good thing is it's made up of 6 pharmacists currently, and then two other healthcare professionals. But they're taking a look not just at what those costs are for those 10 drugs that they're trying to determine, but they're also taking a look at the entire supply chain, because there's money that's out there that's being stolen from the state of Oregon, it's being stolen from pharmacies, it's being stolen from the patients. They're keeping the prices high and making people pay too much for the drugs. So when you're looking for places to make money on this, PBMs are the ones that have all the money that can go ahead and help set up universal health care. They have very, very high budgets. They have a lot of lobbyists that work for them. They have the insurance companies also doing the majority of their fighting for them. So it's been a challenge. If you take a look at the Fortune 500 companies, the 3 biggest PBMs are in the top 15 of 2026. So there's money out there. Oregon's a small state. Like, we can go ahead and make changes in Oregon, and it's not really going to be a drop in the bucket for the PBM. And they're the reason that pharmacies are going out of business as well. So you see the local independent pharmacies going out of business. You see chain pharmacies like Rite Aid going out of business. It impacts everybody except for those that are vertically integrated. So, by the way, is Tom Field here? Anyways, Rice's Pharmacy, highly recommend them. Yeah. So thank you.
Great, thank you very much, Morris. Now we're going to go ahead to the interactive portion. Thankfully, we've had a number of questions that were entered prior to the session. So what we're going to do is we're going to go to 2 questions in the room, 2 questions online, and so on. So the first one, well, person didn't know whether they're going to be in person or on Zoom. Is there a Dale in the room? No. Okay, I'm going to go on to the next one then. So this actually, Isa or Isa, are you in the room? Well, I'm going to go ahead and ask.
Isa's online, I think.
Good.
Online.
Online? Well, if Isa's online, we'll go ahead and just go to Isa if you want to take your mic off of mute and ask your question. I believe this is for Brian. All right, Brian, I'll go ahead and ask the question that she asked. How would pharmaceutical prices, access, and co-pays be affected by the universal health plan that is being proposed?
Well, based on what Mimi said, prices are going to come down. I mean, yeah, I mean, the idea of all this is to bring down the prices and make it affordable for everyone. So, you know, I loved everything I heard. I put on my glasses so I can look at your notes and everything. But yeah, you got a lot of good stuff in there.
Great, thank you. Let's see, we'll do another one. This person said they were going to be in the room. Miles? Maybe our online entry isn't working very well. I'll go ahead and just ask the question. So this is for Dr. McDonell. When universal health systems are designed, the hardest part is often not the principle of coverage, but the politics of allocating resources. As Oregon develops its universal health plan, how will decisions about what services are covered, reimbursement levels, and drug pricing be made, and who will ultimately hold that decision-making power?
Well, I'm glad we went right to an easy one. Thank you. So absolutely, I think that question is so germane because it's true. It is very easy to say everyone should get, all the healthcare. And as we know, from the Oregon Constitution, people believe that it is a right, but how on earth can we possibly get there? And who or what are the decision makers? So I will say, I mean, in terms of the structure, as I mentioned, sort of for a universal health plan, that it would be a, public, not-for-profit corporation with a board that is, people with obviously expertise who are appointed by a governor, approved by the Senate. So that would be for the structure. In terms of the decision making, well, we really want the decision making to be between people's providers and the person themselves. However, there is also the reality of the world that we live in, and that there are finite resources. Now, in Oregon, there's a model that we have through the Oregon Health Plan. And of course, other states have this too. Not all services are covered. So some of the decisions or proposals, I would say, ultimately, when the plan goes forward, it would be the first decision makers would be the people of Oregon, whether or not they believe this is something that is reasonable and can happen. So that's a little bit of a punt to that question. But then when you look at models in Oregon, so I happen to be, there's something in Oregon called the HERC with, oh gosh, now I'm even blank on the acronym, the Health Evidence Review Commission. I'm on the Evidence-Based Guidelines Subcommittee. Thank you. I knew I was going to move that one. And so that actually is, in Oregon, there is a huge, very public way that decisions such as this is like what will be covered is carried out. All of the meetings are public meetings. There are experts who weigh in. There are people that are able to give testimony. And so it is this very broad public process about the reality of that there is not an unlimited amount of healthcare that is available. And so that can be, financed. And so this has not been finalized by the board, but in the discussions, there is the consideration like that type of work would continue. It would continue to be a public process where everyone can be involved, and those incredibly difficult decisions, because they will be made not only by experts and by looking at evidence, but also by individual testimony, which is truly how some of these decisions are made. So that it is not always the decisions are hard. It's not easy, but that's the way Oregon likes to do things, is to get as many people as involved as possible. So that was a super long answer, but it was a tricky question.
That's great. Thank you very much. Eric, online, do we have any hands up on any of the online attendees?
We do have a question. That was in the chat. Tom S. asked, and I don't know if this is specifically for Brian or for the whole panel, could Prescription Drug Affordability Board or some future version of it be the negotiator for drug prices?
Yeah, that's not you.
So with the PDAB, they don't have any authority, but that's always possible to go ahead and give them authority, and that is a really good idea. So yeah, talk to your legislator.
Yeah.
On that answer. So you need to turn that on.
Thanks for the question. Yeah, I mean, I think really we're talking about any entity. Okay, so a perfect example is Medicare is finally able to negotiate drug prices, right? Miraculously, when you're able to negotiate between the manufacturer and the purchaser, the price gets to go down. For years, we haven't been able to do that. So one of the big pieces to having the weight of the state of Oregon, where we're all in this together, and then we all get to say, nope, we're not going to pay that price, but we'll negotiate on that. And I think we've seen the demonstration of that with Medicare drug pricing, with a number of medications, particularly medications some of you may have heard of. It's only been around for about 100 years. It's called insulin. It's something that people, their lives are dependent on. And now we're able to negotiate those prices. The idea is that that's really one of the constraints and total cost of care that we can reduce when we move to a single payer universal healthcare system. And that's the pressure that we need to apply. So, there's some discussions about some entities such as ArrayRx in the state. Could it be something that's posted up? I don't think it has to necessarily be defined, but it is being worked upon at the Universal Healthcare Governance Board.
Marina, is there another online question? Someone with their hand up?
No, not right now.
I'll go ahead and turn it out to the room. Anyone, if you want to put your hand up.
I had a question submitted with.
And your name is?
Andrew R.
You can use the Sonic.
Oh, there we go. Andrew, okay.
Bring that up on screen.
Can't bring it up on the screen because I'm not connected to the, but I can read it, or you can do your best to,
Yeah, it's a long one.
it's a very long one. I'm more than happy to go ahead and read it. Disabled, elderly, and especially those institutionalized and houseless community members positively, hoping more nonprofits can form around health, free healthy kitchens with delivery, occupy medical efforts, especially in rural areas, which are really having a problem.
Yep. Pago cuts after the Pago cuts after the everybody knows about the Pago cuts after the midterms that the Republican poison pill.
Pay as you, right. And you're talking about needing the IRS to step in and investigate things, people in prison, public officials across the state.
We have a lot of corruption with the police departments here. I've been told they're using confidential informants and people that they catch with drugs to deliver drugs to certain places, and they're involved with trafficking, and the cartels are paying them off, and it's a real corruption problem here, and it affects our health. That the houseless are having issues with methamphetamine and fentanyl, and they're taking that stuff off the streets somehow. And
Right. Here, Tony, I think, wants to chime in.
Thank you for the question. I think I'll just take probably the piece that I can articulate a bit further too, as far as attention and mental health. We have struggled in the state of Oregon. We have really put in place a number of different interventions. In my service on the Oregon Health Policy Board, it's a particular area we have really paid attention to. And I think when reference to our conversation today, the Universal Healthcare Board has really drawn up a roadmap that I think would really provide an equitable access to mental health services, and looking to meet people where they are. Right now, mental health parity is although we've put in place the ability to try and reach that, we have not met that. We also do not have the number of providers in mental health that we need in the state. So I think that when you have an entity such as the Universal Healthcare public corporation to say, and this goes to, we do not have enough care in rural communities as well. There are many different pockets because they're not profitable. Mental health doesn't really pay. And it's not a public good we're paying attention to, right? That's really what this is about. It's making sure that people get the care they need when they need it. And I think that the Universal Health Service has really put some innovative thoughts to people, something like in a community health clinic such as mine. We have colleagues that are psychologists, clinical social workers, but then upwards. And so we have an increased ability to put a prioritization where we need to put that dollars to make sure we're going to get the good outcomes we can. So thank you.
Yeah, I wanted to put that to everybody, but I guess the primary part of the question was, how do we get organizations that support the large healthcare institutions outside of those institutions? Was sort of the gist of the question, like, get them started, help.
Sure. I guess my observation of that is that the prioritization would come from public meetings, and the public in this public corporation for the Universal Healthcare would put the priority there for that. We wouldn't need all these different segmented haphazard processes that are taking place. We can put a true emphasis on it.
Great. Got a question there and then over there.
And the sonic voice to go with it. Well, first of all, thank you all for doing the dedication and the work that you've done to do this. It takes people like you, and that's how it's going to happen. So thank you. I really appreciate that. And I'm 83 years old, and so I know what I'm talking about this stuff. But the question I have is one of, I think it's practical and very real, but it's kind of ugly. What will motivate insurance companies? What will motivate the huge drug manufacturers? Why will they even want to consider any of this with the lobbyists that they have, with the power that they have in the legislature? How do we address that? How does that come about with all the good work that you all are doing? Corporation, you can see what power in somebody's hands does right now nationally. And drug companies are just not any different than that, but they just happen to be individual corporations. I'd be interested in hearing what your thinking is about that.
I'll go first, and I'm sure we all have thoughts, but we've been let down by the legislators. That's why we don't have good PBM reform yet. So I would say that they need to grow a spine and take a stand and do what's best for Oregonians.
Follow that one.
So one of the potential ways to get a universal health plan in Oregon going, as we know, one of the things Oregon also loves to do is by ballot measure. And ballot measures can be very, very, very powerful. However, they clearly need a lot of work before something gets on the ballot. So in other words, that kind of the work, for example, like organizations like your organization, Healthcare for All Oregon, these organizations where people are becoming informed of what the possibilities are and are able to put their input into it, that's the kind of work that can happen. And despite there being powerful lobbyists, I think that the legislative bodies certainly do listen to the people that they serve. And I think that is, anyway, in terms of how this could come forward, yes, it could come straight out of legislation, but it also could potentially come through a ballot measure. So in terms of the very practical logistics, that's some of it.
Really important question. That's why we're here. That's why we're here. That's why you're all here. It's all of you. And it's people online. And it's a lot of people coming together. And I think it's the people drawing a line in the sand to say that I mentioned a lot of statistics today. It is only going to get worse. Okay. We've done all these different interventions, these small incremental reforms, and it has been in the benefit for a number of certain corporations and businesses that have built up to get a lot of return on investment for that. And I think there's a reckoning. There's kind of two ways that in the world that we've answered this question, how to make healthcare equitable and accessible to people. You can do it like the German style, where you basically regulate the heck out of insurers, right? Or you can go a little different way, where you go like the UK, or you go like Canada, or you go like Taiwan, and you do a single payer. You can pick one of two roads most of those ways. The United States has chosen to do the middle and do nothing. Okay? But we are where we are right now. And again, I'm going to tell you, in a year from now, well, actually, even the last 15 years of my career, I'll sit in front of somebody and they came in because they lost their diabetes meds and they just lost their toes. Somebody just came out of the ER because they couldn't get albuterol for a simple asthma attack. And then they're in bankruptcy and they can't afford to put food on the table. The number one economic issue facing this midterm election is healthcare affordability. You're not where we were at 15 years ago. We're not 30 years ago. We're in 2026. And what I would say to this is, it's people power. And we need people to speak up. We need people to realize that even if you have employer-sponsored insurance, what does that really mean when 50% or 15% of Oregonians can't fill a prescription, can't get a doctor's visit, can't go get treatment that they need? And I think we need to reconcile that we can go two roads, but if we keep going this way, it's not going to play out well. And I think people are really understanding that. I think people are really fundamentally seeing that how immoral and unethical it is for us to continue to do that. And the other part I'll add to this equation is that you've got a lot of providers, a lot of healthcare providers are like, yeah, I'm done. And they're not going to continue to practice this way. If you just go down the road to Eugene, I mean, I'm sure most of you know the impacts of that community. And it's coming. Private equity is coming. PBMs are coming until we really say, nope, we want something different. And I think we really need to get behind that. And so Healthcare for All Oregon, come join us. Come be part of the solution. People have different ways they can contribute, but we really need more people, and this will come to a ballot. And we need more people to come up because they got a lot of deep pockets. And what we need is, a lot of issues like civil rights. People didn't really believe that was going to happen until it did happen, right? This is a movement, and I think we really need people behind it.
Thanks, Tony. Looks like we've got a question over here.
I'm interested in how you speak writing. I would like to know, okay, how you see the universal health plan integrating with the existing health plans like Medicare. So I currently have Medicare and a supplemental plan. And if I'm also then paying additional income tax so that universal health care can happen, would I be getting some care through universal health care and somehow be able to transfer my benefits from Medicare to universal health care?
That, yes, that's a tremendous question. And there are a couple different models and a couple of different roads that it could go through, but I'll kind of explain what the sort of best case scenario, what the most integrated, what we would be hoping for. And of course, as you mentioned, like you are people who are on Medicare, who are Medicare eligible, receive Medicare benefits. It is true, their funds come from the federal government. Funds also have come from people contributing along the way and also contributing in real time in a variety of different ways. Some people do pay Medicare Part B premiums. Some people pay additional funds on top of their Part B premiums. And then, of course, there's copays, co-insurance, and et cetera, et cetera. So in a ideal situation, the funds that a person would have federal funds that would come to support people who are Medicare eligible would all come and essentially would all go through a universal health plan. So you wouldn't have your Medicare plan and a universal health plan. It would be just the universal health plan. There are a couple of different funding proposals right now looking at ways to ensure that people who are on Medicare, if they, for example, one of the sort of things that is out there is that if people have to pay Medicare Part B premiums, instead of individuals who live in the state of Oregon paying those Part B premiums, that either they would either get a tax credit for paying those Part B premiums, or that actually a universal health plan would just pay the Part B premiums. The reason that would happen is to get the funds back to get additional funds from the federal government. So that's one thing. But the idea being is that you wouldn't need Medigap insurance, or if that it would all come under essentially just through one plan. And again, that's like best case scenario, the ideal way, because there are the funds now. People, and I mean, this is the reality. If people have very high incomes, because of the way a universal health plan, some of the funds would come in because through a personal income tax. People who have very, very high incomes, who maybe are on Medicare, would end up being taxed and might end up paying taxes. The vast majority of people would, who are on Medicare, would not necessarily pay more. Most would pay less overall. And so it's not a simple answer, but really, I think the idea, best case scenario being just that, not multiple different places that you're putting money or pots of money or getting different types of care. The care that you get would be seamless, and it would just be, you and your providers through that unified financing. Well, that was pretty long, but
Actually, we're gonna go online. We've been neglecting them a little bit. Eric and or Narina, do you guys have any questions online?
Eric, do you have any questions that haven't been covered yet?
I've got three that are lumped together. We do have Edie online who's had her hand raised for a bit, so if she could take herself off mute.
Yeah, we'll take Edie. And then we have two other questions online, Fritz.
Okay, let's get those going.
When I talk to people, there's two things that come up about this. And this is something that my husband very much argued about. I'm afraid of it because I'm afraid that it won't work and it will leave me owing money. My insurance company works for me. And I tell you, it did. It did. Our motor insurance, he died last summer. Our motor insurance paid everything. And when you've got something like that, why change horses? Secondly, I'm wondering how how will voters know how much they personally are going to have to pay? Okay, you can say, oh, it's going to be less than what you pay now. It'll be about what you pay now. People want to know more. So those are the two problems I've encountered.
That is, I'll take the second one first. That one's a little bit easier. I'm so grateful to have the expertise that I have for the people who are the volunteers on our finance and revenue committee. And then also we have some incredible consultant groups who are working on this. What would essentially be a calculator. That would be an online calculator where a person would be able to put in some of their own demographic information. Everything would be confidential. Maybe the amount that they currently pay on healthcare and essentially their income, and people would then get an answer. Okay, this is how much I would pay under a universal health plan. So that is in the works. It hasn't been rolled out because the plan hasn't been finalized, but that's definitely something that is in the works. If people are interested in to see sort of maybe what that would look like, there's a Medicare for all calculator. It's a national one that people could, it's not associated with the Universal Health Plan Governance Board, just so people know it's not like our plan, but just to give people a sense of like, oh, what would that look like? So you put in the amount of income that people have, their healthcare, personally what they pay currently, and it will kind of give people the idea of how much they would pay. So that's the easier part of the question. The more challenging part of the question is, well, if it is not broken, why would I want to fix it? Kind of question about, well, and it's delightful to hear when people's health insurance is working well. I worked for a health plan. I worked with wonderful, terrific people at the health plan that I worked at, and I feel like they provided great care for people. And the issue being that happily that you all were in for you, that it worked out for you, but I would say that the vast majority of the people, that is not their experience, and not because of something nefarious that people who work at health plans are trying to do, but because of the reality of the costs and how people are ending up paying for their plans. So I think Tony's going to jump in here.
Yeah, I might just add that there are really good people in insurance companies. There are really good people at BBMs. There are really good people at hospitals. The game that we're playing right now, that we've been playing, is a game board that is going to continue to go uphill and get more difficult. It may work, pretty well for this family. That's great. But as mentioned, Dr. McDonell here, is that there's a lot more difficulties for the broad majority of people. And I could go to Vegas tonight. I'm going to bet two things. Healthcare costs are going to go up, and your premiums are going to go up. And how much more are we going to allow for the system to extract from us that it's taking away from our wages? It's taken away from our schools. It's taken away from, so many things in our life with this, that healthcare is going to continue to eat more of our GDP unless we really want to start to put some cost controls on this and also really deliver equitable healthcare. I really want to put a fine point on this. I've worked at a community health care clinic for my career, and 3 people walk in there with the same illness. And one is on Medicaid, one's on Medicare, and one's on commercial insurance. The networks that the Medicaid population gets to see is very small compared to what is taken by the commercial insurance. That right there is very unfair. That is impacting rural communities, and it's impacting marginalized communities. So that's another point that I think we need to stand up, that if we really, and then as a state, we want to reach 2030 goals of equitable healthcare access. This is how we need to do it, is finally say, we're going to pay, we value those lives, whether you're on Medicaid, whether you're on Medicare, or whether you're on commercial insurance. We do not, the difference in what we paid for those different lives, again, is an immoral system. So I hear, that, but again, we're paying too much and we can do it better.
We're coming towards the end. One more question online and then we'll do one in the room. So let's see if we can make it quick. Eric, you had one more online?
Yes, we had some that were grouped around healthcare costs. The question is, have you looked at Canada witnessing long waiting times, overtaxed citizens, doctor shortage, emergency rooms full for hours and days, waiting for admissions, basically a caution to protect private hospitals in our system here. Related to that is how to get the lowest cost to the system. So those are two questions that are kind of linked to cost. And a question of what is an evidence-based response to the claim that there's going to be substantial tax increases with a decrease in care and quality. So those are kind of the questions I'd like to lump together, if that makes sense.
I think that's all related to Canada. And I know these were some misperceptions about it.
It's just propaganda, am I right?
I could just say a stab at this, to break it up. When you look at patient satisfaction compared to multiple different countries, and you look at the Commonwealth Fund, they actually did a review of the top 11 OECD countries, and we're pretty low. Canada's up there, as well as a lot of European countries with that. With respect to cost of care, well, actually, let's go to the waiting lines with that. One thing in Canada is that primary care access is really rather robust, you know, and so if you think getting in the door right away, that's really where the first point of entry should be. And from my observation and reading on this, I haven't observed anything where the waiting lines in the ERs are excessive in Canada, although I don't have exact data on that. But I can tell you, if you go down the road to Eugene, it's a little bit of waiting time. And that's because of the consequences of the game we're playing in that community, that as we continue to do what we're doing in healthcare in the United States, that community will have more communities that will appear like Eugene. And so that's another, back to our prior question in response to that, is that's the consequences, that's the trade-off when we continue to continue with the healthcare system that we have.
And I'll just add to that another country with a universal health plan, which we have an expert here, Dr. Chun-Wei Chi. Taiwan is actually ranked the #1 country for healthcare, right, for patient outcomes, and has a unified health plan system. So again, certainly the board and the committees and the joint task force before have very much looked into other countries, other system, what is working in other places. And one thing is certain, that there's not one system that is perfect, and that the systems do need to change. And I think we need to be, cognizant of that. But that Dr. Germann mentioned the United States in terms of healthcare outcomes, not even patient satisfaction, healthcare outcomes, we're doing very poorly. We're not doing well by the people in our country. So not only are we exceptionally expensive, the healthcare that is coming out of our country is not exceptional. And so I think that a universal health plan will not fix everything magically, but it certainly can go a long way towards being able to provide that basis of healthcare, so we can certainly improve health outcomes while not bankrupting people.
Right. Yeah, I just want to give a quick scenario regarding the access issue. My sister had lived in Portland, had a broken implant in her ankle. Took her 9 months. She had good coverage, 9 months to be able to get into the OR to get that broken implant replaced. So we have access issues here as well. So last question in the room and we will wrap up.
And I want 10 seconds to make a quick comment.
You got it.
Just engagement rate of Gainesville and the whole this area. I love the fact that you guys are learning and advocating for the best outcomes from countries around the world. And I think that you're to be commended. And I would say I have one tough question for you. When you think about all of the people now who have jobs pushing the papers to please the system to get everything worked out and all that stuff, with AI coming in too, what's going to happen to those folks? It's just another troublesome time when people are scrabbling to find a job. And have you guys figured out some way to ameliorate the hardness that might propose in that? Thank you.
Again, this may sound a little bit waffly, so I don't have the exact answer to that, but it's definitely something that is being looked at. And one of the things that I think about when we certainly think about AI and potentially being able to produce some tremendous efficiencies. And so a decrease. And if you think about a simplified billing system, especially for hospital billing, is just absolutely so labor intensive. It's incredible. So, but of course, lots of really nice billing people. So, what is going to happen with those people? And I do think that it's certainly with this change and with AI, there will need to be retraining and a rethinking. However, if we think about what are the things within healthcare that really bring value, it generally is interaction with other humans and being able to transition some of that work. I think I've been really fortunate to work my whole career with people who are community health workers. And now that's not going to be everyone's calling, and people have different needs, but I do think that there is, as we move away from one type of service, a different type of service could be rendered that will actually provide much more benefit. So, not perfect, but at least that's some of the things that we're looking into.
Great. So, just one tiny bit of perspective. Chen Lai Shi is here tonight, and he's on the board, and was the main consultant in the Taiwan system that has the #1 patient satisfaction. And he's at last year's Healthcare for All Oregon conference. He said something that is stuck in my head so strongly. After we win, that is no time stop speaking that the system will have to be tweaked and tweaked and tweaked. Nobody's going to create a perfect system right off the bat. And we need to keep our work going right on the
Great, thank you, Mark.
Thank you all.
We're going to go ahead and wrap up. I want to thank our panel members. Thank you so much for taking the time to share your information and take our questions. Audience online and here in the room, thank you so much for coming and interacting with us. This has been very good. Online moderators, Holly and Eric and Narina, thank you so much. Of course, all the volunteers that helped out to finally get us through our little tech problem earlier. And apologies for the lateness on that. Again, I want to remind you, on your chair is a piece of paper. It's the survey. We need your feedback, please, just to make sure that what we're doing is what you need us to be able to do to continue to help educate you and provide you opportunities to learn and interact with us. Narina is going to be putting a link in the chat for those online, for the online survey. So again, thank you all. And again, if you can, donate to help us continue to do this work. But the most important thing that we need to do, and we heard it a little bit earlier, is, as Mark said, we need to keep this this going, right? And so we need all of you to continue to educate yourselves and then educate your friends and your family. And one way you can do that is ask them questions about what they're experiencing, and chances are, if they're your family, what they're experiencing in our healthcare system. So engage those people, because when it comes right down to it, if it does go on a ballot measure, studies show it needs to poll at least 60% or better to be able to actually pass with a 51% majority. So we need to make sure, and we need all of you to help us educate people. So again, thank you for your time. If you have any other questions, you can email them to us at outreach@mvhca.org, and we can certainly forward them to the panelists, and we can get that back out to you as well. So again, thank you all very much for your time. Take care. Be safe getting home tonight. Thank you.